The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Welcome to Mental Health Now. I'm your host, Matthew Shapiro, from the National Alliance on Mental Illness, New York State, or NAMI as we're known. The show's purpose is parallel to NAMI's mission of providing education and support to individuals and families impacted by mental illness, as well as raising awareness on a wide range of mental health issues. Our goal of this show is that it will be a place for you to find help and to find hope. Along these lines, the state agency responsible for delivering help and hope for people with mental illness is the New York State Office of Mental Health, or OMH as they're known. We are fortunate today to be joined by Dr. Anne-Marie Sullivan, the Commissioner of OMH. And just as a little background, OMH runs the largest state-funded psychiatric hospital system in the country, with over 24 hospitals, including 2 of the world's leading research facilities. They also have field offices throughout the state, and we're excited to provide you with an overview about the work they conduct. Just a little background on Dr. Sullivan. She was appointed Commissioner in 2013 by Governor Cuomo. Prior to this appointment, she had spent years on the front lines of psychiatric care, serving as the Senior Vice President for the Queens Health Network, and she was also the Director of Psychiatry at Elmhurst Hospital, also in Queens. Upon learning of her appointment, many of us in the mental health advocacy community were very excited to learn that an actual MD with real lived experience of the problems facing the delivery of care had been appointed to lead OMH. And Dr. Sullivan has more than met our expectations, as her wisdom and experience have been matched with a consistent display of empathy and kindness that makes us fortunate to have her as a commissioner, and we're honored to have her as a guest today. So welcome, Dr. Sullivan. It's great to have you.
Oh, thank you. It's a real pleasure to be here with you, Matt, and to be here with NAMI.
Oh, well, thank you. And we're very lucky at NAMI New York State to have such a wonderful partnership with OMH and to help the 1 in 5 people in New York who are impacted by mental health issues. And I always say, there was 1 in 5 people who will be diagnosed with a mental illness, but everyone throughout their lives will face mental health challenges, and we're here to provide support to all those people. So just as a start, I know I gave a little bit of a background about the work that OMH does, but I'm sure most of our viewers aren't familiar with the agency. So can you discuss a little bit about the work you do, both statewide and here in the Capital Region?
Yeah, the Office of Mental Health has two kind of roles. One is we're a direct provider of care and services, and the other is one of planning for the state and licensing and overseeing a whole operation of a multitude of programs. So on the direct care side, we have 24 hospitals. We serve about 35,000 outpatients a year. And we have lots of respite beds for adults and for kids. We provide crisis services and mobile integration services and a whole host of community-based services as well. We have about 3,500 inpatient beds in total. On the licensing side, there are 4,500 programs in the state, and we license and kind of oversee those 4,500 programs, and all these services together serve about 730,000 individuals across New York State. So we're one of the biggest state mental health systems in the country.
Wow, that's remarkable, and we're very lucky to have such an intricate system. Just for a little clarification for viewers, when you say respite beds, verify what you mean.
Yeah, respite beds are places where there's 2 kinds of respite beds. One are respite beds, which we call non-medical respite beds, which are really there when an individual is in a little bit having a crisis, or sometimes the family just needs some space, some time. And they are staffed by peers and by professionals, and you can stay there anywhere from 1 to a couple of weeks.
Gotcha.
Then we have medical respite beds, which are really a diversion from inpatient, a way to help individuals not have to go through an inpatient admission. And there's a little more support in those respite beds that include a doctor some nursing coverage, and some social work coverage as well, to help individuals maybe get, if they're in crisis, to get over the crisis without having to go through a hospitalization. And there's lots of peer supports as well. So all the respite beds are built around a peer support system, and work very closely with families.
Well, that's great. Those definitely two things that NAMI New York State feels is very important, both peer supports, and we have many peer programs like our peer-to-peer and our Inner Own Voice program, and of course, family support, and even peer support for families like our family-to-family program, which is so important. So in talking about the hospital system, obviously one of the big changes in the delivery of mental health care right now is the downsizing of hospital beds and switching care to community-based services. Can you kind of discuss the thought process behind that transition and give us a little update on how it's going?
Yeah, sure. I think, every system has to have some hospital beds. So there's never an intention here of not having hospital beds. The question is, do you have the right number? And can you avoid hospitalizations by providing the right kinds of community-based services? And I think that's where the system is going. So when you have respite beds, when you have crisis intervention teams, when you have home-based services, those kinds of services in the community, it's been shown all across the country that you don't need as many inpatient beds. And you can kind of provide the care when people need it before you need an acute hospitalization. So we're working on that in New York State to shift some of the care from the inpatient system to community-based systems. And we put up now at this point about almost $60 million in community-based services across the state that have enabled us to lower some of the beds, and we're going to continue to do that. So every time we lower a bed, we get dollars to reinvest into the community, which is a really good deal because you don't want to lower beds without having the right community-based services.
Right, it has to be a balance. And this is a little commentary, I don't expect you to speak on this, but from NAMI New York State's point of view, we want to make sure there is a dollar-for-dollar investment in bed reductions that are invested in community services, and we are a little concerned that the governor isn't investing enough, and I'm not going to have you comment on that, but if you want to learn more about that, we certainly invite you to visit our website and visit our advocacy section to see our views of the governor's executive budget and some of the gaps that we feel.
Just to say, though, that I think, I just have to say that I do think often states close beds with no reinvestment.
Right, well, that's true.
So we have been reinvesting about $110,000 per bed. Now, there's a little controversy on this one section of the budget, which I won't go into because it'll take up all the time. But overall, let me just say overall, for the 440 beds, for 400 of those beds, $110,000 has been invested per bed closed. And that's pretty good.
No,
that's about $44 million. So, just to say that.
It's a good start. We'll leave it at that. But I think one concern that people have too, they hear beds closing. I think you provide a lot of clarity to the different type of beds. I think people also fear that there's not going to be enough crisis beds, and that NAMI New York State certainly feels that no one should have to travel more than an hour to get to a crisis bed or crisis services, which obviously in rural areas is tough. But can you kind of just talk about where we are with crisis service beds and if they're part of the reduction?
We're in the process of putting up as many as we can with some of the reinvestment dollars. So at this point, I think we have about 80 or so adults across the state and probably about 40 kids. We need many more.
Right.
And one of the good things is that crisis beds will now be paid for through the HARP enrollment in Medicaid managed care. So that's going to help us with the growth of crisis beds because they're now going to be paid for instead of just out of state dollars. They'll be paid for as a Medicaid benefit. So we're already in the process of trying to figure out where we need, just as you said, where NAMI's right, where you need crisis beds, how you need them in the community. Sometimes you can have 3 or 4, sometimes you have 6 to 8. It depends. And we're going to be working with managed care companies too upon where those are needed and getting the dollars to kind of grow the crisis respite capacity across the state. It's a very important service.
No, it's very important. And maybe you touch on some things that I think a lot of people are very confused about, especially families and people living with a mental illness. We hear all about these changes in Medicaid services, and you talked about HARP and some of the other programs. Can you just, Phil, give us a little bit of insight on the Medicaid changes and how that will impact the mental health community?
I actually think, I know people are nervous about it, but I actually think it's a good thing. Basically, for the seriously mentally ill before, everything was paid on a fee-for-service basis. Now, all those dollars are being moved into managed care, but with that, managed care will pay for things it never paid for before, like crisis respite, crisis intervention, employment supports, peers, education supports. Those things were never paid for out of the Medicaid benefit before. So in the HARP, which is called the Health and Wellness Program, HARP benefit, all those services can be paid for now through the Medicaid benefit. That kind of makes sure it's always going to be paid for. You know, state aid can fluctuate with budgets, but when it's in a medical benefit, that's a really good thing. So we're very excited about this. We're in the process of setting up those services across the state. We have about a year and a half where most of them will still receive state aid before we just depend on Medicaid. So there won't be any loss of peer services. There won't be any loss of the services that are already there. They're going to continue to be paid for. But it's a wonderful opportunity. The other good thing is that the benefit for both health and mental health will be under one roof.
Right.
And that offers us an opportunity to make sure, because sometimes the mental health system hasn't been as on top of the health care of those with serious mental illness. And this gives us the opportunity to do that. So it's very exciting, I think. Managed care, I think, offers something that we didn't have before in the payment system.
Right, and certainly that integration of physical health and mental health is so important. I mean, we say it all the time, you can't have physical health without mental health, but it goes both ways. And for someone to be able to visit a physician and a mental health specialist the same day and get all their care under one roof and not siloed is huge. Getting back to the crisis, you know, I was amazed to learn about all the services that we offer right here in the Capital District when we had Bill Dixon on last time. But one of the things that NAMI also is a big proponent of is assertive community treatment teams, or ACT teams, and how they play a role in the crisis situation. Can you explain a little bit about what they do and how they function around the state and here in the Capital Region as well?
Yeah, I think we have a little over 80, probably about 84 ACT teams across the state. And ACT teams serve about 68 individuals at any point in time. And they're really a comprehensive, actually the first literature that was written about them, they called them hospitals without walls, because they include psychiatric time, nursing time, social work, peers, wrapped around an individual. They go home, meet the person anywhere the person wants to be met. You don't have to come to a clinic. You don't have to come to a formal program. And the ACT services are comprehensive, so they do a really great job at providing services when and where individuals need them, especially for individuals who can't easily access or don't really kind of easily take to our structured kind of clinic settings. ACT teams are critical, and ACT teams are mobile. They go where the client is. They go where they're needed. So I think, you know, we're pretty close to the number, but we might actually need a few more ACT teams in the state, and we're looking at ways to think about doing that, because you should really have access. It's critical service, good service.
Well, that would be, it's a good point. Now we know it's something else we can advocate for, which is so important. One of the things we talked about siloing when we talked about physical health and mental health, you know, as we're learning more about mental health and mental illnesses, we're also learning more about substance abuse and addiction services. And, you know, for a long time, it looked like there'd be a merger between the Office of Mental Health and the Office of Alcohol and Substance Abuse Services, which, you know, there was definitely some exciting possibilities with that, because people do end up in silos. Either you get your services in one door or the other, and very rarely both. But it doesn't look like that merger is going to happen, correct?
Probably not, no. I think that there's so much happening in healthcare now, and when we did the forums across the state, people thought that, just as you said, there are important things to do together. They didn't think it was the right time to actually merge. But we are preparing. We don't have it yet, but we're preparing with OASIS key initiatives that we're going to work on together to ensure that we're both sides better at integrating services. Well, so I think I'm going to start that right away. We're not going to wait for some future date. But we'll be coming out with that probably in a few months. We're working on some key areas that we know we have to work better together on.
Oh, well, that's fantastic, and we'll definitely keep our eyes peeled for that.
Good.
One of the other exciting things about the Medicaid redesign is that they're doing a lot of investments for children's mental health services, which are much needed. Can you talk a little bit about that?
Yeah, children's mental health services will start in managed care about a year from now, actually, January 2017. And there's 5 new services that are going to be embedded into the benefit, and one of them is crisis services, crisis intervention, a whole host of home-based services, such they call them psychiatric home-based treatment, some psychosocial home-based, and peer and family advocacy services will now be in the benefit. And they will not be just for the kids with the most serious problems. We're expanding that to include eligibility for kids who are beginning to have serious trouble. So it's a little more prevention. So it's going to be a wider range of kids and families that will be eligible now for these services. And there's actually the investment this year is $7.5 million. Next year's $30 million, and then eventually another $30 million on top of that to enable these services to be a wider group of individuals. So we're really, really excited. And it's going to be based on need now, not a whole bunch of what used to be somewhat bureaucratic eligibility
Right.
requirements. This is much more based on need, so it's really good. So
Oh.
we're looking forward to this. I think it'll be very, very helpful for the kids.
Well, that's excellent. And as we know, obviously, the quicker that we can intervene when it comes to mental illness, the better the long-term outcome will be. And that gets me to one of the OMH programs I'm most excited about, which is On Track New York. NAMI New York State is the outreach partner for NIMH. And for years, we heard about the recovery after initial schizophrenic episode studies, especially all the research being done here in New York in our world-class research facilities. And it was great that OMH really took that research and ran with it and invested in this program, which gets people right after they first, well, I'll let you discuss the program and the success it's had and how it sprang across the state.
Yeah, no, I think it's one of the most exciting developments in years, actually. And I think it catches individuals when they have that first psychotic episode. And it works intensely with the individual and with their family, with their social supports, with their schools, with their employers if they're employed. And it works to give people a vision of what their life can be. Maybe they have an illness, maybe they're going to have to deal with this illness for a long time, but it helps them make their goals then and there. And goals that fit a young person. Everybody wants to, have a job, finish their education, get married, have kids.
Right.
And it helps kind of develop that setting. And with that, the outcomes have been remarkable. It includes psychiatric services, peer supports, it includes some social services, et cetera. And with that, the quality of life indexes by all the research go way up. Individuals stay focused and stay involved in treatment. So the outcomes are outstanding. And I think it's because it's tailored to people's individual needs. We all know we have to do this, but so many programs don't do it as well as this program does. And On Track New York, now there's 10. We're going to expand it to 20
That's
over the next
fantastic.
year. And that'll serve, I think, about 1,000 individuals in total. But we still probably need to expand more. But that's a really good beginning. And it'll be all across the state. All across the state.
It's so exciting. It's really captured the imagination of so many people. And you see the New York Times talking about it. And the Mental Health Channel just did a great episode on someone getting care right here at Columbia Presbyterian Hospital in New York State. So it's such a fantastic program. And one of the other really exciting OMH-led initiatives for youth and school-based is Project Teach. And I know we had Dr. Perkins at our education conference talk about it, but I'm sure many of our viewers aren't familiar with that either. Can you describe a little bit about that program?
The place where a lot of kids who are having trouble are found are in pediatricians' offices. But pediatricians often don't have the support of someone to help them understand what's going on. Project Teach links child psychiatrists across the state, telephonically and with telepsychiatry, to those pediatricians so that they can have an easy consultation and decide whether this is an issue that you want to make a referral for, something maybe the pediatrician can handle. They teach pediatricians if the pediatricians want basic psychiatric skills, et cetera, if they need it, or they can just call them for a conference call or for a consultation. And we're working now with 2,200 pediatricians across the state, which is a good number, and we've done, I think, almost 9,000 consultations, and we want to expand it. And we want to make it so that it's easily available for any pediatrician across the state, and we're going to be sending out an RFP this year that expands it even further. There's a real shortage of child psychiatrists. This lets you spread that expertise across counties and across all kinds of geographic barriers and gives the pediatricians what they need. So and it's very helpful. It not only diagnosis, it helps with prevention. So they can give advice to pediatricians, to families, to help prevent the crisis because now they're able to talk to them. So it's a really great program.
No, it's fantastic. And that epidemic of the shortage of children's psychiatrists is not just a New York State problem. It's a national epidemic. And I think it also goes into something else that we've talked a lot about, and that's screening during physicals and having your general practitioner ask you a few basic questions about your mental health to try to nip these situations in the bud. And of course, we need to get to that as well, and that's a story for another day. But one of the things I also want to talk about, when we had Bill here, we discussed at length the difference between people living with a serious and persistent mental illness and someone who might be having a acute psychiatric episode or a bout of depression or something like that. And NAMI, of course, was founded by families of people who had the most serious types of mental illness, who back then, 30 years ago, the outcomes weren't as good and the prognoses weren't as good. Can you discuss a little bit about the different types of care for people who have a serious mental illness and someone who mental illness or symptoms might not be as severe?
Yeah, I think, for serious mental illness, it's just like for any other chronic illness. I mean, it's if you have diabetes, if you have chronic lung disease, the care that you're going to need is going to have to go over years. It's going to have to go over long spans of time, and you need to build a relationship with a caregiver. You need to have all your supports, your family, everybody else involved in that treatment, because it's going to be something you're going to have to deal with, for many, many years. So it's a different approach. Episodic care is more like a little bit if you have a pneumonia, you go see the doc and maybe you take the antibiotics and you feel better. More episodic care also exists in mental health, and sometimes that's for depressive episodes that might be brief. It can be treated sometimes with talk therapy. It can be treated sometimes with medication. So, but the important thing is to kind of get the help you need when you're feeling kind of bad for whatever reason, and then get someone who can put you on the right road to what you need. I think both are critical. I don't think you can say you just have to treat one end of the spectrum. You wouldn't want your personal primary care doctor to say, I'm sorry, your cough isn't serious enough for me. I can only treat this. Well, so you've got to treat the whole spectrum of mental illness. You just do.
And I think there certainly are a lot of mental health advocates who think you have to sacrifice one end of the spectrum for the other. I think they believe that there's not enough pie to go around, and that a lot of times they think, well, we treat people who are easier to treat, but forget about people with serious mental illness. I don't believe that's true. I think we can provide care for everybody, but one of the things you touched upon too that's so important, we kind of touched upon it a couple times, but within On Track New York, involving the family, and something we talk about a lot at NAMI is forming a recovery team between the person living with the mental illness, the family member, and their service providers. I think we have a lot of work to grow those relationships, and I think a lot of times families don't know how to talk to providers. A lot of times they come in, they're angry, they're frustrated, and there's a lot of blame to go around. I think improving that and really creating true recovery teams is a big help in that process.
Absolutely.
No matter where in the spectrum you are.
Absolutely. Nobody gets better alone.
Right.
And nobody gets better just talking to one mental health professional.
Yeah.
I mean, it's the whole team that has to do it. It's the mental health team, it's the family team, it's all the social supports that someone's involved in. And we really lose something on the mental health side if we don't take all that into account. We're not using a force that's tremendously powerful in helping people heal and get better. So I think sometimes we haven't done so well with it, to be honest, but I think we're learning and we're doing better and better all the time, and NAMI definitely keeps us on track.
Well, thank you.
Make sure that we do it well.
We try. Our families are always very passionate, but so are the people we have that are living with the mental illness, and we've seen the power of working together, and that's something we definitely want to focus on and bring more providers in to show that family support is a valued part of recovery. So kind of along those lines too, what would be the best advice you would give to either a friend or family who thinks that their loved one might be having some sort of psychiatric issue, whether it be acute or long-term, something that, they see a change in behavior, maybe just a little depression that they're concerned about? How would you, advise them to communicate to the loved one and encourage them to seek help?
Now, I think it's important when talking to somebody to emphasize that, first of all, there is help. You can get help. And that if you're suffering, it's just like any other illness. It's not something to be ashamed of or to feel bad about. And then I think you have to, it's hard, but you have to speak up. You have to maybe talk to, you can talk to your primary care doctor. You can talk to your physician. You can look up on crisis hotlines. There's numbers all over the place of places you can call anonymously too and say, where could I get help? If you're living near a medical center, you can always call the medical center and say, I'd like to talk to someone in the mental health department, and just explain what the issues are and say, do you think this person could use a consultation, whatever. We have a website in the Office of Mental Health, and I think it's mainly not to be afraid to ask the question. It's fascinating because if you have something medically wrong, people are not shy about saying, I got a pain, what could I do, who could I help? It's the same thing. I think you have to be open and ask, and just go to the medical profession, go to people you know, and also you can seek help directly from the Office of Mental Health, from any of the providers in the community.
When I was having mental health episodes as a young person, something my grandfather said to me is, he quoted ancient, I think it's an Asian proverb, but even the longest journey starts with the smallest steps, and taking that first step can be the hardest. So one of the things we're actually very excited about and NAMI helped advocate for is there's going to be the new tax checkoff to create a mental health anti-stigma campaign. So kind of encourage people to take the first step. So can we talk a little bit about that?
Well, first of all, I think it's great that you did it, and I hope, I think the government, we put in the budget like $200,000 that we're assuming the budget gave us because they're assuming we
Right.
don't get that much. And we're going to be working with NAMI and other advocacy organizations about how you think it would be best to spend those dollars in terms of, but I think stigma, I agree with you, I think stigma is the biggest thing that stops individuals. People are still afraid of mental illness, they feel ashamed of it, they feel bad about it, so they don't speak up, they don't take the first step, which is exactly what you're saying. So I think that tax checkoff is great, and I think it's going to offer us an opportunity, hopefully, and I just hope lots of people will, check it off and give a few bucks to help fight stigma, which is important.
So as people are filling out their taxes now, important, look for that tax checkoff box. And something we talk about a lot is hope starts with you. So that's an easy step people can take to help create mental health awareness here in New York, and it's going to help a lot of people. So one of the big questions, too, obviously, as we're getting near the end, is that, as we talked about, being diagnosed with a mental illness can be scary, confusing, both for families and the loved ones. And what would be, again, your advice for people just taking that first step? And again, you talked about how it's a long road, but how do you think that the biggest difference, I guess, in outcomes between maybe 30 years ago when NAMI started and now, and the things that people are able to accomplish in recovery? I mean, what's your perspective on that?
Well, I think we've made great inroads in terms of understanding all kinds of mental illness so much better than we ever did before. And whether it's psychopharmacology or social skills or education or anything, we have a skill set now. Psychiatric illnesses, when you actually compare them to medical illnesses, have a higher recovery rate. Nobody wants to look at those numbers. But in terms of like heart disease, diabetes, more people do better with the interventions we have in mental illness than they do in general physical chronic illnesses.
And does that include people with the most serious
yes,
schizophrenia?
Still the improvement factor. The improvement factor is sky high. So I think it's fascinating that even though all the research shows this, that stigma is still hanging around there, that it's not as accepted. But yes, the new treatments, the new approaches, the work that you've done and NAMI and others have moved us a long, long way. The sad thing is, I think people are still reluctant to ask for help, and I think that that's where people have to take a deep breath and ask for help. And what often finds, it's so fascinating because when I've had individuals come to me, after they take that first step, it's not so hard. They get a lot of support. They get support from family. They get support from friends. Get support from the professions, etc. So it's really that very, very first step. And don't be afraid to ask. I often have parents, especially young kids, who say, "Well, I'm not so sure." Ask, just like you'd ask about anything else, and just try to understand. And don't hesitate to ask question after question after question until you feel that you understand what's going on. I think often that happens to people ask, and then they kind of pull back. Keep asking the doctor. Keep asking the nurse. It's what's going on until you feel comfortable that you understand what the problem is.
Because that road to recovery is never straight. It's
up and down.
And you need to know, if you hit a curve or a bend in that road, to ask what's going on. And like you say, never afraid to ask and inquire and educate each other. I think that's a big thing. Educating your family, educating your friends on what's going on with you. Unfortunately, we're actually out of time. This went by so quick. We're going to have you back for a future episode. So many more things to talk about.
Thank you so much. It's been a real pleasure.
Oh, well, thank you for joining us. We're really honored to have you. And thank you for watching this episode of Mental Health Now. And as I said before, when creating a mentally healthy New York and a mentally healthy capital region, hope starts with you. So thank you for watching, and thank you for being a part of the hope.